I'm Kami Maddocks from the Ohio State University James Cancer Hospital. When approaching a patient with relapsed or refractory diffuse large B-cell lymphoma, I first try to evaluate if they're a candidate for aggressive therapy, in which case I recommend treatment with salvage chemotherapy and autologous stem cell transplant. And if they do not respond to that therapy, then I recommend CAR T-cell therapy. And a patient who's not considered for this aggressive approach, my primary approach in the last year has been using tafasitamab and lenalidomide. While this therapy was not studied in patients with primary refractory or early relapse disease, I have been using it in this setting as I feel like using other chemotherapy has been shown to be not as effective in this setting. When looking at the other approved agents, bendamustine, rituximab with polatuzumab. I've used polatuzumab in order to try to bridge patients to CAR T-cell therapy, although I try to avoid bendamustine prior to collecting T-cells. And I've used this therapy in patients who progress after receiving CAR T-cell therapy. Loncastuximab has not been approved for very long now, but I would also consider this as using in a patient to bridge to CAR T-cell therapy who had progressed on CAR T-cell therapy, or both of these regimens in patients who I've given tafasitamab and lenalidomide to, but have not progressed after that or do not respond to that therapy. I've not really used selinexor in relapsed refractory diffuse large B-cell lymphoma. And when I look at the use of this agent, I consider it to be an option in patients who are not candidates for other approaches or who have progressed after other approaches and are not candidates for clinical trials. This is an oral therapy that may be easier to administer in patients. They don't have to come to clinic as often for it. And so this is where I would consider the use of this agent.